Welcome back to the Orthopedic Tutor channel. Today we'll be discussing about the rotator cuff tear part 2, which includes the management of rotator cuff and also the post-management program of the rotator cuff tear. Be sure to log into my previous videos which describes more about this continuum of disease starting from shoulder impingement, the subacromial and subcoracoid impingement, calcific tendonitis, and even the next video of what happens to the shoulder if the rotator cuff tear is not treated well. So today's video will focus on the management of rotator cuff. As in any condition, the management program should always include non-operative and operative means. For the non-operative treatment methods, it is always indicated as a first-line treatment, especially in asymptomatic full-thickness tear or in a non-compliant elderly with age more than 65 years old. We know that age population, usually patients are non-compliant and they do not need perfect function of their shoulder. And it is also indicated if there are any present sign of rotator cuff arthropathy. The indications of rotator cuff tear to be managed non-operatively in the athlete population if there is any signs of combined instability and cuff tear. Well, the modalities varies, but it usually includes activity modification. We generally would advise our patient to avoid forward flexion to more than 90 degrees because in this position it will even impinge the tendons even more because we have known that certain positions of the shoulder such as the flexion and adduction will decrease the space available between the acromion, and therefore other modalities should include strengthening of muscles such as strengthening of the rotator cuff, using anti-inflammatory medications, and also giving subacromial injections. Well, we have known about the non-operative treatment modalities. Sometimes operation is still needed because the indications is sometimes patient came to us with significant pain that is still unresponsive to conventional treatment, and sometimes it is also recommended in full thickness acute tears. Remember, acute, not chronic tears. The basics for treatment of rotator cuff tear can be divided into 4 basic types, and each of them has a very specific indication. You need to do a subacromial decompression plus rotator cuff debridement in cases where there is low-grade partial tear. Remember that decompression means that there is a previous compression, so you need proof that there is indeed a subacromial impingement causing the rotator cuff tear if you want to do this one. The next would be the rotator cuff repair. Rotator cuff repair also has specific indications which include acute full thickness tear, 25% bursal sided tear, or 50% partial articular sided tear. This percentage is very different, and we have covered these basics in our previous video, the rotator cuff part 1 video, that the bursal sided tendon has a higher vascularity compared to the partial articular sided tear, and therefore even a small size tear should be repaired because there is an increased chance of healing there. And for the partial avulsion of the supraspinatus tendon, if there is more than 7 mm of bone that is exposed over there, then you need to do an operation. Other techniques that could be done is the tendon transfer, and also it is also usually indicated only in massive cuff tear with various techniques which include the pectoralis major tendon transfer or the latissimus dorsi tendon transfer. While that is all the surgery that could be done, some types of surgery tends to replace the whole joint with a total shoulder replacement or arthropathy. Well, these are usually only indicated if there is significant damage and there is an irreparable massive tear with evidence of glenohumeral arthritis. Well, after covering all those basics, we need to know that there are several techniques to perform while doing the surgery. It would include the classic open repair, which has been forgotten for a long time because most people now do arthroscopic repair. There could also be a mini open or deltoid sparing technique, but the currently used technique is the all arthroscopic technique. The all arthroscopic technique includes several types of basic things to do, which include margin convergence, which is shown to decrease strain on a lateral margin in a U-shaped test. And then we could do an anterior interval slide in which we release the anterior attachment of the supraspinatus to be able to slide it forward, and we could also release the posterior aspect of the supraspinatus from the infraspinatus, which increase the mobility. You could also do a concomitant long head biceps tendon repair because most studies have shown that there is negligible difference between tenotomy versus tenodesis after concurrent rotator cuff repair. Other thing to do is the footprint restoration. It is already hypothesized that a larger footprint will improve healing and the mechanical strength of the rotator cuff repair. Now, talking about this margin convergence and interval slide, I would go back to the materials that I have gone over at the first video of this rotator cuff tear, which is this ones. As you might notice that what the authors are doing here is actually repairing using the principle of margin convergence. They will try to suture each of these margins together using that particular principle. And if the tendon needs to be slide to the lateral aspect, you could imagine that this is the lateral aspect of the shoulder, this is the anterior aspect, this is the posterior aspect, and this should be the neck of the patient. And the anterior sliding is used in certain cases such as the, let's take a look. Okay, this does not show the anterior sliding, but if you are to perform an anterior sliding, then you would release this whole attachment. Anterior sliding release the attachment of the supraspinatus to the anterior tissues, and after you cut through this area, the whole tendon can be slid laterally and then sutured back to its footprints. In the posterior sliding technique, you release the attachment between this supraspinatus tendon with this infraspinatus tendon, so you release it right here, and then you could pull the whole tendon laterally to reattach it to its footprint, and that is called the posterior sliding technique. Well, although this technique can be used in various different patterns, there are certain types of tear that needs to be paid attention to, which is the first, in the young population that has concurrent massive tear or atrophy, you should do tendon transfer instead of repair. And in the older population with massive tear and has a poor prognosis, you should move on directly to arthroplasty. In this case, a reverse total shoulder arthroplasty. Well, after knowing the management plan, you should pay attention to some of the post-management things that may come to your practice. First of all is prognosis. Patient will generally ask you how well they will do after the surgery. Well, failure rate is usually higher if the patient is treated with a revision surgery or RTSA, and failure rate should be higher in this certain population. Patients age more than 65 years old with massive tear, presenting with moderate or severe atrophy, and with increased fatty infiltrations as shown in the tangent sign. You could look up for that in the first video of this rotator cuff topic. And failure rate is also generally high if the tear has retracted to the level of glenoid. It is also generally bad or poor or associated with poor outcomes if the patient has diabetes, is currently smoking, does not do any rehabilitation, and multiple tendons are involved. Well, after knowing the prognosis, you should also be aware of the complications which may occur following the surgery. Sometimes 6 to 8% of patients may have pain and weakness following surgery. The deltoid could also be detached if you are doing an open approach. There could be a concomitant pain over at the AC joint or acromioclavicular joint. The injury could also occur over at the suprascapular nerve. There could also be infection or stiffness following surgery. While the rehab goes on in a very certain phases, usually this varies according to various authors. Some would use a more simplified algorithm of rehabilitation, but here I'm going to show you a 6-phase of rotator cuff tear rehabilitation. The first phase goes from 1 to 4 weeks following the surgery. The goals here is to maintain comfort for the patient, maintain the integrity of repair, and to increase the range of motion as tolerated without progressing to any full range of motion. And for the second phase, it goes after 1 month or at week 5 to week 8. So for the next month, usually protection of the surgical site is still being done, and gradual improvement of range of motion is being achieved with slight increase in active strength and decrease in the pain and inflammation. Elbow and wrist range of motion, of course, needs to be maintained. Next, we will move on to week 8 to 13, or in other words, the next 1 month, you need to expand the range of motion of patient and avoid any impingement problems. So full range, full flexion and also adduction or too much of internal rotation will indeed impinge the tendons that you have just repaired. So remember to always avoid those positions in the early phases of healing. And in this phase, we also try to decrease any soft tissue restrictions and scarring that may occur due to the surgery. The fourth phase includes the week 13 to 16 following surgery, and it includes maintenance of full range of motion, and we try to improve the function of the patient during these periods. The fifth phase would include week 17 to 21 following surgery. Here we will try to maintain the full range of motion, but also in the same time we will try to return the patient to their functional activities. And initiation of sport-specific activities under supervision is started. Look at the weeks here. It is at least week 17. It means that it is already at least 4 months after the surgery when the patient is allowed to initiate their sport-specific activities. Remember, initiate is not full sport-specific activities but only light sport activities. So the questions that patient frequently ask you is, when, sir, when, doctor, could I do full sporting events? And the answer is the return to normal activities should be done at least 22 weeks. 22 weeks is at least 5 to 6 months following surgery. And it is in this period that the full range of motion of shoulder is maintained and additional strengthening and endurance training is being given. Now, following rehab, it is always important to educate your patient to maintain a healthy lifestyle by also maintaining their sporting activities and also maintaining their diets and their smoking patterns. You need to try to decrease or even, if possible, stop the smoking because it is associated with high failure rate. It is very important to educate your patient afterwards. That would be all for today's discussion for rotator cuff. If you have any questions or comments, please leave it at the columns below. Do subscribe to the Orthopedic Tutor channel if you like to see more of these videos. Thank you.